Bismillahirrahmanirrahim. Thank you so much. Good afternoon, everyone. It's my pleasure to be with you here for the third, probably, and to me, this is a special meeting because it's very unique and subspecialized with an elite group of people. So hopefully it will be another success in the journey. Thanks for the organizers, the scientific committee, and like everything has been great so far. I know everybody has a little bit of mental constipation after the previous lecture. I'll try to match Dr. 1hus's voice, so just bear with me. Huh? I'm going to start with a patient that you might have seen in your clinics or similar patient to your clinics. And the characteristics of the patient as you see it. Patient is known to have scleroderma, limited cutaneous. She is anti-centromere positive. She has recurrent digital ulcers, as you see in the pictures. Her lungs are okay. FVC, with all its limitations, it's preserved. HRCT is very well maintained, no much fibrotic changes. BNB is normal. Echo parameters are normal. And she's coming to visit with you in her annual screening visit. She does not have any specific complaints. What will you do next in terms of pulmonary hypertension? Now we are shifting gears, so stop thinking about the cells and the interstitium, and let's switch to the vessels. What will you do? Do you like to do anything at this point for your patient? Okay, so you will apply the TECT algorithm on her? Okay. Let's move on. We'll get back to her later on. But the patient is really, her echo parameters are normal and she's asymptomatic. So we agree that connective tissue disease contribution to the pulmonary hypertension pool is significant. Anywhere you go, you will find a good number of patients who have pulmonary arterial hypertension. They belong to this category. And among the category, it turns out scleroderma is so important. It's not only just the only one, it's the major one. We do see definitely PH patients related to other CTDs, but we agree that scleroderma is the culprit. This is what we are talking about. And of course, you want to do scleroderma spectrum disease, the same thing. And different registries can show you the big differences in the numbers. يعني احنا probably we always talk about SLE. Everybody gets excited when they talk about SLE. Really, we don't see that many SLE patients who have significant pulmonary hypertension, unlike the other areas where scleroderma is really a major contributor to the disease. And the like out of the connective tissue disease related PH, scleroderma, they tend to do the worst. This is a very sick group of patients that we cannot take them lightly by virtue of their important disease burden and in their overall outcome. Multiple studies has shown and registries has shown that in scleroderma related PH, they tend to do worse in terms of mortality, in terms of like admissions to the hospital and some of the composite endpoints. And within the PH, within the CTD PH, scleroderma tends to have the worst prognosis. And this is a real life experience and evidence from what is being published so far. Now, this FAROS trial or registry again confirmed the same thing. The numbers are not pretty, by the way. This is a real-life study from the US showing that the mortality rate is significant at 3 years, less than 80% of the people despite the treatment. So we are talking about these people, they do have PH-related scleroderma, and it has been reiterated that this group of people, they tend to do worse when they present late. So if they come in advanced stages, their mortality rate is so horrible as is in the functional class 4. And if their DLCO is advancedly low, that means that they tend to have worse prognosis. And that's expected probably because of the duration of the disease. So this is an indirect way to look at the disease being more progressive than other diseases. How do you predict the development of PH? You can have any prediction model, but these are the commonly agreed upon or noticed among the patients who develop pulmonary hypertension. They tend to do somewhat more likelihood, but at the end of the day, when we talk about diagnosis, we have to really diagnose the patient. So if we agree that scleroderma PH carries a high mortality, survival is somewhat worse than others, and there is heterogeneity, as you all know, in the disease itself when it comes down to PH. We're not going to talk much about it, but I'll show you a picture later on, because this particular disease can have all types of pulmonary hypertension. We have different groups, and this patient can have any of the groups. We are interested always in the PAH, which is group 1. So it's another smaller group of the patients who develop PH that we are interested in. It's a complex, and people tend to try to see who tends to do better and worse, and the cluster analysis, it was confirmed in multiple studies. This is the first one, collaboration between France and the US. They found that there are some groups of people that are like the ones who have very bad lung disease, interstitial lung disease, they tend to do the worst, and this is cluster 2. And there's another cluster that performs exactly the same as PAH patients. They don't have much of lung disease, but they do have significant pH, and they tend to do worse than the PAH patients. I'll show you their mortality curves. And there's a group where the pH is somewhat mild and there's a minor decrease in their DLCO, and these are the groups. 61.9% is there for C3, which is the one that's similar to PAH, is their 3-year survival rate, which is considered very low. Yani if you have 10 patients, 4 of them are expected to be dead within 3 years. That's a significant number. When we started, it used to be 50 without any therapy, but this with therapy. So that just shows you that disease is not very easy to go. So probably this will set the stage for what are we going to do about it. Shall we just leave the patient until we discover them by chance, or until they become advanced and they have decrease in their DLCO and they start to have symptoms? So the idea of screening has always been in the horizon. This is an excerpt from the guidelines from 2004. And just to remind you, probably this is when we start talking about pH in reality. Before that, there was very primitive chances. This is after the 3rd meeting for the pH. It happened in France, I think, in Nice, I think. And they came up with this. So people were suggesting to screen these patients, although in the guidelines said, what are we screening for? At that point, there was only one medication available and start of the oral therapies, and we don't know what really the drug will do. So they said, potentially, why do you recommend the screening? And that screening was recommended based on a very not so strong study, retrospective echo study from England, showing the patients who have scleroderma. At that time they called it the primary and secondary pH from the terminology, and they had some small number of patients who happened to follow them up by serial echoes. And they did notice that after 3 echoes or so, some patients who were having low estimated pressures by echo, less than 30, half of them, they remained stable after 2 years, but there's a third of them that they progressed, the pressure increased, and there was a mortality rate of 1, which is about 8% of the cases. But the people who are severe by echo, almost all of them died within 2-year period of time. So that was an indicator that these patients probably, they tend to do worse, and their progression of the disease is fast. And we are talking about within 3 years, a lot of these people are dead. So capture them early, and that's why they were promoting for the screening. This is just a graph showing each individual case in the study, and they followed them by repeating the echo. And as you see by the end of the study, actually both the idiopathic or the primary and the secondary, they tend to do worse. And they came up with that being a male with scleroderma is not good, but definitely the limited form is more probably seriously carrying a worse outcome. After that, there has been some studies. This is in France. They start looking at some screening. This was published, between 2002 and 2003, and they had in their cohort of patients about 600 scleroderma patients. Half of them almost, they discovered some with pH. Some of them were established, and some of them they were discovered during follow-up, and they compared the two. They noticed that when we screen and we start actively looking for the disease, maybe I'm not sure if it's full screening versus early detection, but they tend to have milder hemodynamics. And that was important to shed the light on the true prevalence of the disease, at least in that cohort. Okay. In that cohort of patients, the prevalence of scleroderma was not that much. People were thinking, I remember when we started pH practice in general, we were talking about 28%. It's less than that. In reality, it's probably close to the French group. And now there is a wide publication, even the guidelines adopted, up to 19% of scleroderma will develop pH during their course of existence. Shall we keep going? أستنى؟ حاضر. So this is what it showed. It showed that, the hemodynamics are milder, and we tend to have smaller number of people who will develop the disease. Later on, this is from the guidelines in 2009. And they say all the guidelines were talking about symptomatic. Whenever you wanted to do anything for the patient, wait until they develop symptoms. And towards the end of the paragraph down there, detection of PH may be considered in asymptomatic patients with scleroderma spectrum disease, and the level of evidence is horrible. It's 2BC. So that's in 2009. And that was adopted and predicted in the guidelines that how do you do it? You do it by echo, and even they selected their numbers different than what we normally do. They said if it's less than 2.8, if it's more than 3, and in between. But at the end of the day, these are an echo parameters to look for it. Unfortunately, Dr. Hani will not be able to present the echo workshop for you. Have I known this before, I would have included a couple of slides here just to show you what is it that we look for in the in the echo. So this is an echo-based screening tool that looks into the patients, and annually, it was recommended to be annually, and they look at some cut points with one number only. And again, that was in 2009. Screening of patients, this study was in 2011, and they noticed that, guess what? If you detect the patient by screening, they tend to be in a milder functional classes, and they tend to do better in terms of survival and mortality. This was a huge. And if you detect the patient actively before they develop symptoms and they have an advanced disease, there is a huge difference in their outcome. So this is from the current guidelines. 5 to 19% is acceptable prevalence if you wish. Annual incidence of developing of PH is 0.7 to 1.5. So it's not only a one CT cut of their assessment. Every year they are at increased risk, at least by 1.5%, to develop a new PH. So having normal now, maybe in a year, some group of them, they will develop. And that's why when we start screening, we have to look into account how far they are in their disease and how long they have been, having the disease. So what is screening? In the previous talks, screening was not intended to be screening. Whether you are trying to establish a baseline or you are trying to look for something changes, that's not screening. Screening is intentionally looking for something in the absence of another indicator. And why do you screen? Because the disease might be important, maybe the outcome of the disease might be serious, and maybe a combination of both. Why would you look for something? يعني الأمريكان بقول لك if it's working, don't fix it, and if why لا تسألوا عن أشياء إن تبدى لكم تسؤكم. So you screen only when you have ability to screen. And as was mentioned in the 2004 guidelines, we have only one therapy that's parenteral. People are dying before they get treated. We're not going to go look for patients who are asymptomatic, just to look for the disease that's not very well characterized and start offering them therapy that's not going to be accepted. And we don't know that this therapy will be beneficial. So again, these are the limitations of the screening as we all know it. Today, the story is different. We do have medications. I've shown you evidence that this disease is important. The outcome of the disease is serious, and maybe still we hope that this is the case. Maybe intervening early is expected logically to do it, with the lack of very strong scientific evidence. The screening is not only for scleroderma, the screening is for people who have, as you see in the slide, if you are a first degree relative of somebody who have a BMBR2 mutation, it's worth screening. Now again, we are not adopting this. Lots of places in the world, they don't adopt this, but this is somewhere we can screen. People who are gonna have liver transplant because of liver cirrhosis, there is a small chance they might have pulmonary hypertension, even asymptomatic. So it's worth screening for them, but that's not, again, screening a program. That's a let's say, transplant workup. You just do an echo, and if there is a problem, you carry it. How do you select the test for screening? Which test are you going to do for screening? The test has to, the disease has to be, like I said, the asymptomatic period is long enough to be able to capture it. It's prevalent enough to justify the screening, treatable, and the treatment of asymptomatic patient can make an impact, and sufficient effect on the quality or length of life. These are the characteristics of the disease itself. Some of them available for scleroderma PH, some of them are not. The test itself has to be sensitive, has to be specific, safe, affordable, available, acceptable by the patient. Otherwise, you're going to be making recommendations nobody will follow or afford to doing. And the criteria of the population that they have disease prevalence is somewhat high. They are accessible. You can really outreach them and get them to come to a screen, and they have to be compliant with what you suggest. When we talk about sensitivity, specificity, and this is very important, these are specific for diagnostic tests and screening tests. Just a quick revision of the statistics. By themselves, they change according to the cut point wherever you select your abnormal, and of course always they are linked to the positive and the predictive probability of the detection of the disease, and that always depend on the prevalence. Since we are dealing with a low prevalence, that's always a tricky, and lots of times I'll show you in the studies that you might do all these screenings and you end up not discovering that many of the patients. This is a trial of looking in the early days, looking at the two parameters, the echo and the DLCO, as a good screening tools. And they looked into different cut-off points. The conclusion of this was to be able to detect them and a reasonable sensitivity and the specificity, they will probably be advanced to begin with. The DLCO will be lower than 50, and the jet velocity, according to this parameter in the echo, will be more than 3.4. So this, sometimes you look into it, by that days, Dr. Majdi asked, will they truly be asymptomatic at this level? So I'm not sure if it will be fitting a perfect example for screening. So this is again one of the limitations that came about. What are we going to use to screen for? The echo is not a very good tool to detect early changes in the pH. And have we given the echo talk would have justified this, but this is from the guidelines. Estimation of the pH pressure based on solely of a Doppler transthoracic echocardiography is not sufficient, and you always look for another reasons. Remember the customers. These patients are not working up for dyspnea. These patients are not probably have pH. These patients are asymptomatic. And there has been recent change in the definition of pH by the pressure cut points. This is a validation study looking into if we kept, and they kept the same echo parameters in our probability, 2.8, 3.4, and in between. So they wanted to, see if the change in the definition will make an impact in the accuracy of the test, and it was overall not too bad. This is ROC curve showing you the balance between sensitivity and the specificity, meaning that I do want to have good sensitivity, but I don't want to be capturing false positives. And this is the downline, because false positive means referral to right heart cath, and the patient will end up not having anything. So they came up with the number 3.1 probably is going to provide us with an excellent specificity, which is 100%. When you have 100% specific, that means the probability of finding a false positive becomes much lower. And again, this is like, happened with them 100%. You will, in real life, probably you will not see 100%. So it's always a balance, and that's the way that we analyze the data using this particular statistical approach. This is the recommendation per echo for patients who are working up for pH. The thing that nobody's seen is this graph. They published it online. I had so much difficulty obtaining the graph. It took me a while to capture it. And they published online version of the guidelines from 2015, this graph. And basically, it's not much change, but here, the level of evidence is not the best, but said if the echo is intermediate, echo follow-up is recommended on the left side when you have a scleroderma without symptoms. So this is for asymptomatic patients. Even when the workup is low, when the probability is low, they do recommend follow-up CT scan. That's kind of more going with the annual screening that we talked about. In line with this, before the guidelines, there was Mr. Dr. Khanna and his group. They published some recommendations regarding the screening. And as rheumatologists interested in the field, they wanted to screen everybody. But they agreed only asymptomatic scleroderma to be screened, and the other cases you have to have symptoms to warrant your screening. And of course, they looked into the PFT, transthoracic echo, NT-proBNP, and follow the DETECT algorithm, which was just published right before the release of this recommendation. And of course, that how frequent do you do it? Basically, you do it annually, but there is no evidence even for that. That was adopted by the guidelines, as you know it, and everybody is talking DETECT algorithm. So what's DETECT algorithm? They brought patients. It's a very good study. It was a little complicated, but it is statistical at large. They captured patients who are like meeting all these criteria, and they selected patients who have forced vital capacity more than 40% with DLCO less than 60%, 3-year duration of their scleroderma, and they managed to get multi-center, multinational study. They did have 466 patients. Everybody had a right heart cath. So this is the gold standard in terms of pulmonary hypertension diagnosis, and they start looking at everything. They had so many parameters that was captured in these patients, and then the statistician did his work, and they came up with some parameters that seemed to be important, especially when you put them together. The parameters were FVC, the telangiectasias, the anticentromere, anti-proBNP, serum uric acid, and people sometimes wonder if you're not familiar with this. There are some studies early in the pulmonary hypertension literature showing a relationship between the level and the mortality, actually. People who have higher uric acid tend to do worse, similar to the BNP in a way. And of course, if you have an ECG, if you have right axis deviation on the ECG. These are the parameters that are important to really have a clinical bedside clinic probability of having pulmonary hypertension in a patient who have scleroderma for more than 3 years. If these parameters are met, and of course each one has its power, I'll show you the graph, then they will recommend doing an echo. And based on the echo, there's a couple of more parameters. Again, they did not stick only to the velocity of the blood across the tricuspid valve. They did include the surface area of the right atrium. And then if the results are positive, they will recommend referring to a right heart cath. So this way, they will capture some of the things that echo does not capture, and at the same time try to control the doing everybody right heart cath because of its cost consequences. And so this is a quick way to look at it. Each one will be powered, and they had some number of points that will contribute to the overall score. In the first step, the total number 300 and above, they will go for an echo, and then after that, they will add the echo parameters, and they will add to it and take it. So it is good study. If the first step has a 97% sensitivity and 82% specificity, that means we will capture some cases that are falsely positive, i.e. we do echo unnecessarily. And at the same time, when you do the echo as a second step and combine them, the sensitivity goes better, but the specificity becomes less. That means you will have more people who will have right heart cath than you do like to see. So the DETECT algorithm recommended right heart cath in 62% of the cases. يعني they did the numbers, but if you follow the DETECT algorithm, 62% of the people had right heart cath. يعني أكثر من نصهم، يعني ثلثينهم. يعني if asymptomatic patient بيجيك على العيادة, probability of sending them to the right heart cath is 2 out of 3. They missed only 4%. Of course, the more aggressive you will be, you will tend to miss less. But this is sometimes the balance we always talk about. And if you apply the European Society, you will end up missing much more. 29% of the cases were missed. And less people were referred to the right heart cath when you compare the two. And this is showing you the differences. On the left-hand side, the DETECT was missing 4%, and there was 35%, if you wish, that's the positive predictive value. So if you predict the patient is having PH according to the DETECT algorithm, 1 in 3 will have the disease. But if you follow the echo only, you will miss a third of them, and you will probably guess that you need to send them to right heart cath in 40% of the times only. They tried to improve the sensitivity or the changes in the cutoff points in the DETECT algorithm. They improved the positive predictive value to 47%, but they had start missing numbers. So they missed 15% of the cases. So this is the balance we deal with whenever we deal with the patients like this. This is a quick example just showing you plot the numbers, and according to this graph, and then you come with a probability. You put the echo numbers, and then you come with a probability. I have a better way to doing it. I'll show it to you. The right heart cath was recommended in that case, and you take it there. One of the things that came out of the DETECT, I think this is probably one very important point, about 20% of the patient by right heart cath criteria having pulmonary arterial hypertension, 20% of them, their jet velocity is less than 2.5. Now we were talking about 2.8. A third of them, they had less than 2.8. So if you follow only echo, you will miss a third of the cases. And of course, if it is like less than 3.4, you will capture a good number of them. Still, you will miss about a third of them by doing this. Now, not everybody who had right heart cath have pulmonary arterial hypertension, group 1, because we said the disease is somewhat heterogeneous. There are so many factors that might affect the patient outcome and the probability of PH. And again, we have different types of PH, whether it's the lung, whether it's the heart. And again, smaller number of these people who will be captured by the algorithm does not differentiate. The algorithm tells you to do for the right heart cath, and not still your expertise as a clinician is needed. I did the luxury and the effort of translating to you. If you feel like if you don't have it, you can have it on your mobile. I included the app version, and so you can take a picture of it if you are interested. But at the end of the day, this has been done. So our patient, you wanted to do the detect algorithm. Anybody else felt to do the detect algorithm for her? We have some of the data that's not available, of course, but I'll show you what I did when I put it in the detect algorithm. So you will have the application, and you'll start plotting these 6 different parameters in the echo was recommended. The echo, when I did put the parameters, her echo numbers are really normal. Her surface area is 13 and jet velocity is 2.7. I would have probably not done anything if I just relied on the echo. And of course, after putting the numbers, it's close to the edge. Right heart cath was recommended, and the patient underwent right heart cath, and she did have mild, if you wish, precapillary pulmonary hypertension. Knowing her lung disease is not bad, so this is the true PAH that we would like to do. We could have missed it if we did not do the detect algorithm. But at the same time, remember, you could have sent the patient for right heart cath, and she ended up not having pulmonary hypertension, which is the usual scenario. Yes, we capture more, but again, on the account of doing too much to capture one case. Now, that's not the only. There were some studies on the detect algorithm. Some studies, they looked at it. The cost will be 3 to 4 times more when you follow the detect algorithm than when you do the echo only. And it's not the only protocol available. Australians, they came up with their own screening tool, and they used different parameters. They looked into the DLCO, and they looked into the NT-proBNP, and whether 1 or 2 or none, and they followed the patient, and they did have a good positive predictive value of 22%. If we follow this protocol, we can capture at least 1 in 5 that truly have pulmonary hypertension, ending up doing probably 4 unnecessarily right heart caths. The guidelines do recommend and endorse following the detect whenever it's feasible. And remember, the detect is for patients who are following a specific criteria. If your patient does not follow specific criteria, what will you do? They have not been 3 years. They don't have, let's say, DLCO less than 60%, and or the other parameters is the FPC. So to apply the detect, they have to have all these criteria there. If not, you'll have to resort to developing your own way of screening, but the recommendation is to screen. So the screening has captured a lot of, let's say, space in the current guidelines. And of course, they did mention that, you have to allocate resources. The good news is that I started showing you how bad the disease is. Kana has done an analysis of the published evidence. They almost include a lot of studies. A lot of them are relatively recent, let's say after the detect algorithm, and they have similar outcome when it comes down to comparison with PAH. So the CTD PAH disease is probably as good in the treatment and as good in the outcome and overall. So there is hope if you capture it early. So the differences between the PAH and CTD PAH is not that much. So hopefully by now I encouraged you to think of screening and know the limitations of each screening tool. And maybe later on we'll capture a couple of questions to complete the story. Thank you.